So good evening, dear colleagues and friends. It's my pleasure and honor to be between an eminent speaker in very important topics and session. I think it will be one of the most strong sessions. As usual, we are having a very, very eminent speaker in this field from all the world, and they are the pioneer of this subspecialty. We will have Dr. Prasan Rao as a moderator of this session, and we will have Dr. Prasan Rao. He is a specialist ophthalmologist and vitreoretinal surgeon, medical director, Midcare Eye Center, Dubai, UAE. And he will also have a talk. Dr. Prasan, no? You have a talk?
Yeah, there's a case.
Yeah, case presentation. Okay, later. Okay, so and you are. Can you show me the program first? Okay, so we will start with Dr. Prasan. Please go ahead, Dr. Prasan. You can start share.
So, good evening, everyone, and Dr. Amri, thank you very much. And it's an honor for me to actually present in front of stalwarts in the field of ROP. So, mine is a very straightforward case. It's just to stir up some discussion and what are the controversies in the management of ROP. So I call it completion of treatment with a question mark, because we really don't know whether this is the right way to do it or no, but it seems at this point of time as a potential option of treatment. So the case is about a baby who was born with a gestational age of 22 plus 6 weeks with a birth weight of 498 grams. And the child also had a respiratory distress syndrome. Some blood transfusion was done. And with sepsis and anemia. So the first screening was actually done at post-menstrual age of 29 weeks and at 30 weeks. The view was pretty hazy because the child actually, you couldn't see the disc very clearly as well. And no plus was noted. The actual first time we could actually find was seen at 31 weeks. Now, unfortunately, we don't have a fundus camera with us, but we did have the camera for doing some imaging of the child later in the management of the patients. So at 31 weeks, these are the drawings from the fundus chart, the ROP screening chart. So at 31 weeks, the child had zone 1, no ROP with no plus disease. And you can see this is a very small area of vascularization. In the past, some of the authors would call it posterior zone 1 as well. There are terms used for this, but according to the ICROP, I don't think so it's a valid term, or it's not used nowadays. At post-menstrual age, 32 weeks, this was zone 1. There was no plus with a early pre-plus, and there was no ROP again. 1 week follow-up, this child actually developed zone 1 plus disease with a very flat neovascularization. So the red marks here actually indicate the flat neovascularization. So considering that this is zone 1 with an AP-ROP, we decided to do bilateral injections for this patient. And unfortunately, Avastin is not available, or we don't have the option of using Avastin. So this patient was treated with ranibizumab, both eyes. As is expected, within a matter of few days, there was a significant improvement. Zone 1, the plus actually resolved. There was quite a good regression of neovascularization. And we continued following up this patient at 34, 36 weeks. The vascularization started extending. In the left eye, actually, it went into the zone 2 as well. But at 41 weeks, again, post-menstrual age, this child had posterior zone 2 with a recurrence of ROP. At this point of time, there was stage 2 extending almost, you can say, 8 to 9 clock hours in both the eyes. And there was an early pre-plus in both the eyes as well. Back to the baby at 42 weeks, again, there was a recurrence of stage 3 ROP with a posterior zone 2. So at this point of time, again, a decision was made. Considering that there was a large area of avascular retina, we had a discussion with the parents, and we decided to actually go ahead and do Lucentis injection for this baby again. And again, as I expected, most of these babies will regress very well with the injection. And there was regression of stage 3. And we continued follow-up for this baby, and eventually the vascularization extended up to the periphery. So we continued examining this baby right from 48 to 60 weeks. And at 60 weeks, we were really finding it difficult, which is practically, the case when we have these large babies. It's really difficult to depress and examine them in the clinic. So normally my viewpoint is at about 60 weeks, I decide if there's an area of peripheral avascular retina, I generally plan to do an angiogram. If at that point of time we had the option of using the angiogram for this baby and then go ahead and do some laser treatment. So these are the angiograms of the baby. This is the right eye of the baby, and you can see this area of peripheral avascular retina. You can see the abnormal branching, the lack of dichotomous branching, and in that extends almost 360 degrees. The nasal part seems a little avascular as well. You also note this area which is very ill-defined. You can't say whether these are areas of capillary dropouts. We really don't know, and they go all around. And somehow, what I've noted is whenever I do angiogram, I see this area which probably demarcates some sort of a choroidal flush as well. But there's absence of a lot of this flush going all around, all around the retina. So these are the images of the right eye, and similar image in the left eye. You can see the avascularity going all across in this eye, and you also see some sort of a leakage, a very faint leakage. So we don't know whether this is leakage or this is staining of the terminal buds, because this is pretty much late in the angiogram. So we don't know if it's a leak or it's just staining of the terminal buds. So at this point of time, we decided to do the laser. So this was the laser done in the same session. So you can see the laser being done all around the avascular retina. And fortunately, this child did very well. So post-op follow-ups, again, we didn't have the fundus photos for this patients because we had the camera only for a very short period of time. So because it was a demo machine. So post-laser, this child is really doing well. And at last follow-up, the retina seems well vascularized and the child is pretty stable and is on follow-up. So points for me to ponder, and which are always the controversial thing, is how to treat recurrences when they're in zone 1, zone 2. Especially when what happens is the recurrence is at the site of the previous ridge or the present ridge. Do we consider injection? Do we do laser? And the most important thing is how to tackle the problems of peripheral avascular retina, to treat or not to treat, because these can lead to recurrences of ROP. You can have structural changes, lattice, retinal erosions, atrophic holes later on causing a retinal detachment. There are some recommendations that we have to follow up these babies for a post-menstrual age of at least 65 weeks. But again, when do we time a laser? And is FFA really necessary when we're doing a laser? What sort of a laser we need to do in the areas of peripheral avascular retina? Can it be confluent, or we need to do scatter? And if only do we treat the avascular retina, or sometimes you see avascular zones within the zone 2 as well. So these are all my points. And the reason I put up this case is because it will help me to discuss, and I want answers from Dr. Mangat, Professor Subhadra, and Dr. Tapas, and of course, Dr. Susanna, to just help me out, whether we are doing things in the right manner or should something have been done differently. So thank you very much for your kind attention.
Thank you very much, Dr. Prasan, for this case presentation, and excellent. So you ask all of them except me, so I will not answer you. I will ask Dr. Subhadra first. Okay, Dr. Subhadra, please.
Absolutely great case, Dr. Prasan. I think you taught at least a lesson today to me that the second injection would lead to vascularization of retina. We are very scared. Mostly, we do feel that it may not arrest the vascularization, but you have shown very convincingly. And that is something I think which is a great education, at least for me. Dr. Subhadra will also have some experience of that, and Susanna is here. But the second injection, this was really wonderful. You had in posterior zone 2 these vessels, and
Yes.
the vessels are going all the way to zone 3 with second injection. That's wonderful. Absolutely very impressed. So this is what I wanted to say, first of all, apart from what the questions you have put. I think we have Dr. Subhadra, Dr. Susanna here. So let's start with them. Okay.
Okay.
Well, hello.
Go ahead, Susanna.
No. Go on, Rabba.
Okay, I just wanted to say a few things. I think an excellent case, managed extremely well. Just few additional points that when we see the patient first time, sometimes when the disease is so posterior, it's very difficult to know, is there ROP or there is no ROP? When only few vessels are there, like the first visit when you saw. So I think the clues for me to say that there is an ROP, even when there are 4 vessels only in the retina, or just some tweaks of vessels seen around the disc, is one, if the pupil dilates slowly. So that is a sign that this eye has an ROP. And second is, if the vessels, whatever vessel we see, they are not dichotomously branching. So if they are looped, then it means this is ROP. And we may wait for a few days to give that injection, but we know that this is ROP. So sometimes people are confused when it is just few vessels in the half zone or something. Is there ROP or no ROP? So I would not label that as no ROP when that type of retina I see. Of course, if you had FFA at that time, you would have seen all the pathology of the ROP. But I think even at the first visit, maybe the ROP was already there. Unless we say it was dichotomously branching vessels or the pupil was really dilating very well. The second thing is that before and after injection, and as we follow the baby, I think very important to emphasize the systemic care, especially the anemia, the lungs. So for lungs, it's very important to see for nebulization, chest physiotherapy, keeping the nose clean, and then the weight gain. So if they are not gaining weight, they need supplements in their breast milk or whatever, and of course the oxygen management and sepsis. So the systemic management of these cases is extremely useful, because data has shown that the recurrence is more when any of these systemic factors is not appropriate or not taken care of.
Okay, thank you very much, Dr. Shibada, because the time is running. I'm sorry, but if we can get a short, very short from Dr. Susanna, if something different what Dr. Shibada mentioned.
Yes, it's very similar, because when you see it very early, you can be an oxygen-induced retinopathy. So you must treat the oxygen and simultaneous the retinopathy. So it's multifactorial. The second thing is about the angiographic images. And really in these babies, we have usually a patchy choroidal filling. And it's not, I think it's not ischemia, but somehow the choroidal is this patchy filling. And in the OCT, you have a thinner choroid than from the other babies without prematurity. That's the funny images from the choroid, somehow from that ischemia, that perhaps it's not ischemia, it's just a different contrast with the choroid. That's all. Then
Thank you very much. I think we can now move, and if we have any other comment about Dr. Prasan case, it will be at the end. Can you show me, please, the next speaker, Dr. Susanna? Slide.
Oh, it's 9
okay.
now?
Yeah, I will introduce you. Dr. Susanna Teixeira is a consultant in medical and surgical retina. She's an ophthalmology department, Cruz and Vermelha, I think, Portugal.
Cruz Vermelha, yes, it's the Red
Portugal.
Cross.
Yeah, because this one is a little bit difficult for me to pronounce. Sorry for that.
It's Red Cross in Portuguese. So I cannot
and
start the
talk,
screening share.
Okay. Yes, please, you can start sharing.
Thank you for this kind invitation. And I congratulate everyone and say hello to all my friends here in the panel that I don't see for a long time. Oh, almost a year. I hope everybody is okay, like it seems. So I'm going to speak about not the acute phases of ROP that are very limited in time, but all the problems that come after those initial acute ROP. And there are a lot of changes after the baby is premature and premature with ROP. So there are changes that we must look for in the pathology of the vitreoretinal interface, vascular changes, macular findings, optic disc nerve findings, and all the other things that are glaucoma, strabismus, and refractive errors that we must look all lifelong of the babies. I begin with the tractional sequela, that are those that really matter a lot to us and that we can treat if it is needed. The interface of the retina and the vitreous is very tight. I mean, there is no planar cleavage. So all the tractions from the vitreous reflect in the retina, and you can have retinal detachment, but sometimes you don't have retinal detachment, but just schisis of the retina. As you can see here in the OCT is most easily to see. And that schisis along the life of the baby can threaten the central vision and can distort the central vision. So we must always look for distractions that we cannot really see. So this is a normal arcade from a baby, a normal baby. But if we have a lower, narrowest angle of the vessels, we know surely that we have some kind of traction. And this traction doesn't stop in the acute phase of the baby. It goes long and long, it's going on, going, sometimes all the life of the baby. So you can have an ectopia of the macula, you can have a normal macula, but you know from these narrow angles there is some kind of traction in the periphery. And this traction can be progressive. So I've got this baby with type 1 ROP, I injected, he had a relapse disease, then I made laser. And 1 year later, you can see here the fibrosis, you can see here the laser and a little traction, but I thought, as there was no significant vascular activity, it was all okay. So the baby disappeared and came here 4 years later. And 4 years later, the baby has a progressive traction because of an anterior fibrotic proliferation that I was not expecting this. So I made surgery, made a vitrectomy, but it was ongoing. Although we made laser, we made an injection, laser, it looked well, but it was too late when finally we saw there was a fibrotic proliferation. So we must always look careful for these babies because it has this kind of ectopia and I don't know how to say this, a fold in the macula, so it has a low vision. So those kind of babies that we treat, there was a problem, they are babies to look careful all life because it can be ongoing distraction. Now we have also, after we use the anti-VEGF treatment, we have those very persistent avascular retinas that can be a place where we can have some kind of retinogenical problems like lattices, holes that we don't have again retinopathy. So retinopathy acute disappeared. We have no tractions, but we have an abnormal link between the vitreous and the retina. So we may have holes and tractional and lattices that we must do laser and always look for it. It's very nice to do the laser and very nice to do the angiography to really look where the problem is and surgically do this laser. I usually don't make laser of all the avascular retina, but just when those lesions appear. Of course, we must never forget that all this can be linked with the appearance of retinal detachment in the adults, and usually by the 30, in my experience, by the 30 years of age, in the place between the laser and the normal retina, we can have retinal detachments. And those retinal detachments are very difficult to solve because the retina has some kind of inner PVR. So it's very difficult to make this kind of retinal detachment. With the use of anti-VEGF and even in the spontaneous regression of ROP, we can find some vascular changes that were most enlightened with this intravitreal anti-VEGF. So we have easily that patchy choroidal filling that we can have in babies injected with the anti-VEGF, but also in babies that have a spontaneous disappearance of the disease. So I think it's not only the anti-VEGF that originates this patchy filling, but also the retinopathy of the baby. So it's very interesting, the images that we have in the angiography. Then in the retina, we can have funny features like the vascular loops, like anomalous non-dichotomal vessels, like vascular shunts. And in the beginning, we thought the vascular shunts were arterial venous, but no, most of the shunts are venous. It's very interesting. And you can see here the venous filling And this is a shunt, venous shunt. So it's very interesting and stays for life. For all the life, they will have these findings in the vascular, in the injected eye, as we can see here, but also in eyes that had a spontaneous regression of ROP. So what is the strong of the anti-VEGF, or what is the cause just about the ROP and the prematurity, in the impact of this in the normal vascularization of the eye. What worries us more, and is a point of discussion, is the persistent avascular retina. But Ellen Mintz-Itner in 1994 already studied this periphery of the retina and almost tell us that some eyes, because the baby is very premature, some eyes won't have spindle cells in the periphery. So it's not the persistent avascular retina may not be an ischemic retina, but just a retina that has no vessels and no functioning. So I don't know if we must all make all laser of the peripheral retina. I've got very peripheral retina, very stable peripheral retinas, and more than 2 diameters from the ora serrata. Like in this case, I've got a peripheral retina that I'm following for 8 years, and there's no recrudescence of the disease. But usually when I've got these babies, I like to follow them, and I have the privilege to have angiography, so I can see if there is some kind of activity in this periphery or not. So in the babies that have zone 2, very peripheral zone 2 and zone 3 avascular, I do laser. If I do angiography, if into the angiography I see no activity, I just follow them. And sometimes I see this kind, as you saw, of impregnation, not diffusion of activity in the periphery. In these cases, I do the laser of the peripheral retina, but interestingly, even with laser, you can have this impregnation. So I think it's the fibrovascular, like in the adults, you make a PAN photocoagulation and still see the retina having this kind of impregnation. So you can do laser and still have some kind of activity. So we don't have an absolute answer for how to laser, or if you must laser all the peripheral retinas. Then we have macular findings that are hallmarks of babies, premature babies and babies with retinopathy of prematurity, and the shallow febrile and mainly the persistence of inner retinal layers are a hallmark of prematurity and of retinopathy of prematurity. Some studies, even in adults, show this. And there is a very interesting study about the use and the maturation of the macula that is best with bevacizumab. The external retina matures better with bevacizumab and less better with laser treatment. Also, we can see in the answer to your question, we can see a thinner choroid in the babies that were premature and had retinopathy of prematurity, so that's patchy in the angiography. And interestingly, I've got a baby that did the injection 16 years ago, and we have somehow not an epiretinal membrane because there is subclinical, so I don't see anything in the ophthalmoscopy, but in the OCT, I can see some kind of condensation of the posterior vitreous in front of the macula that I'm following up. Finally, about findings in the macula of the babies, we have an avascular zone, slow little avascular zone, and we can see it in the OCT, so almost no avascular zone, so persistent of the vessels in the macula, and it's also a hallmark of the premature macula. We also have optic nerve findings, but I'm not going to speak about all of them. That now we are trying to make them as a potential biomarker for neurological development of the baby. And there are very interesting studies about this. And we must never forget that the glaucoma is more prevalent all the angle closure and wide closure, wide glaucoma, open angle glaucoma is more frequent, not only in the acute phases, but in the chronic phases. Refractive errors, we must never forget them, and we must accompany the baby all the time, because the myopia, we know that myopia is linked with the laser and the number of spots of laser, and astigmatism is connected with the presence of ROP. Must never forget strabismus and sometimes low vision, just because there was ROP and there was prematurity. So ROP is a lifelong disease, doesn't stop with the treatment of the acute phases, but is a patient for all life. So that's what I have to say just about this long-term sequels of ROP. Thank you.
Dr. Susanna, this was an excellent presentation, and we, we very well highlighted that ROP is a lifelong disease. Actually, Dr. Mohammed Amri had to leave, so can we have some comments from the other speakers? We have about a minute to discuss. So, Dr. Mangat and Dr. Susanna and Dr. Tapas.
I only have one comment to say here. I think we do not know as yet when we should laser the peripheral retina. If we are late and that fibrotic switch is already there, then we are in trouble. Then we'll have that traction, what you have shown. So we really, at this time, I would say we have to study more that which part need laser. I think that is what we are, and at what time. I think that time we have not really at this time.
Yes, because you saw eye laser, I injected eye laser. I thought everything was calm. And 4 years later, I have a direct macula. So with the peripheral, with avascular fibrotic periphery with traction on the posterior pole. So I had a macular fold when I thought I did the best for the baby. So we must carefully follow up these babies to understand exactly what is said. What should we do? Because there is no rule. Each baby has its own disease. So there is not an absolute rule. And even lasering everything is not the answer.
Tapas, you want to say something?
Yeah, Susan, one query on your presentation. In one of the follow-up of the fundus images, in addition to the laser marks, I could see few multiple depigmented laser-like spots within the vascularized retina. Did you notice that? And what it could be? Because I see many of the cases developing similar pattern of multiple multifocal depigmented spots within the vascularized non-laser retina.
Vascularized non-laser, I cannot say. Well, usually I do laser just of the avascular laser. That's what I usually do.
Yeah.
Sometimes if I am desperate, I go to the posterior retina just near the ridge. But is that what you are speaking about? To do laser behind the ridge?
So your picture showed, there are inferior to the disc, there are multiple round and discrete depigmented spots.
So
quite
Tapas,
away from
Tapas, we had reported these. We have reported this in our papers twice. We have reported, others have also reported. These are RP atrophy patches. We think these are sites of choroidal ischemia or choroidal injury or RP atrophy. We are seeing them very consistently after intravitreal injections. Very rarely we see them post laser also. I think people are missing. I used to miss, but when I read a publication and I went back to the pictures, I could see them. So I think
I will go back to the pictures. What I find is this patchy choroidal filling in the first times of the fluorescein. And even in babies that had ROP and had a spontaneous regression, I can see this patchy filling. And it was funny to me because in the normal babies, I don't see those patchy filling. But I never realized those white spots.
Can I just interject? So because of want of time, can I just request Dr. Mangat Dogra sir to actually start presenting? we have 3 speakers and we have about half an hour. So let's try and finish the talks and then we can have a discussion. So I would like to invite Dr. Mangat Dogra. He's a former professor and chairman of ophthalmology, Advanced Eye Center, PGI Chandigarh. And he's going to talk on aggressive ROP.
So I've been given this topic of aggressive ROP, which is the new term, which has come very recently. And so I'll be just, I have just this financial disclosure, being a speaker for both Bayer and Allergan. I think this aggressive ROP has various names. The last one is aggressive posterior ROP. Still all publications are with that name now, recent ones. Then we had very posterior zone 1, fulminant, atypical, rush disease. These were all in past. You see, that's how I think this is one at least disease which has got a lot of changes over a period of time. And this was from the last, the ICROP revisited, that is the number 2 classification, where you see this was defined as aggressive posterior, and all the features which are shown here, that you have these flat vessels, and you may have sometimes also brush-like vessels, sphere plus, which might be zone 1 and posterior zone, that is what it was. And in our country, we started seeing more and more of them in the outborn babies. And almost, I would say, half of these babies, they were APROP. And now the recent classification, in the third edition here, of course, I'm not going into the classification, talked about posterior zone 2 notch. So we have this aggressive ROP to replace aggressive posterior ROP, and subcategorization of stage 5. And of course, already PAR has been talked here quite a bit, and that is something, a good term which has come up. And it is because of the increasing recognition of this, and that this disease can be beyond posterior retina, and in larger infants, particularly in the region of the world with limited resources, that this new term, aggressive ROP, has been recommended. In fact, I just want to highlight here the 2 papers which has been listed, and because of which probably this term came. We are part of one of them here, and which was called hybrid ROP. In fact, I'll just go. This was a publication in 2012, where we started seeing many of these mixture, but and that is what we published that time, because we could not fit them into any of that time's ICROP classification. So this is what, in fact, this is the picture already published in that. We had these flat vessels in the ridge here. Even another one, you can see much more prominent ridge here and these flat vessels. So these kind of things were happening. So that is what has basically happened. So they had, in fact, very given an important kind of discussion about our paper. And this is from the same, that you have this kind of a ridge as well as flat vessels, and this becomes part of the aggressive ROP. And there are others which I'll not go into details. You have same kind, maybe involving zone 1, maybe going into zone 2, or you have on angiography all these with loops which are avascular. So all kind, you see different kinds of configurations are there. And I think we published extensively from our country about this, and these were the initial paper we wrote when this classification came in 2009, retina. And then this was a great publication from another group in South India. And also, I think what I would like to say here is, since in this presentation, aggressive posterior ROP is still I'm using here, because that is what we have reported. Because for this, the laser treatment has been reported with a success of 55 to 84% in various series. So that means many of them, and in our series, we had a 71.4% success of laser, because this was an era when there were no anti-VEGFs. So we were only doing aggressive laser to these babies. And we also looked at, because of this reason, many of them going into detachment, that which cases go into retinal detachment despite your very good laser which you have done. If there is a posterior zone 1 ROP, APROP, or there is a pre-existing or new onset fibrovascular proliferation. So I think some of these things, even I think Dr. Prasann Rao mentioned about this posterior zone 1, or you have pre-retinal hemorrhages, or some of other factors which are not that important. And we did publish subsequently about posterior zone 1, and this was probably debated also, but probably not included in the classification. They put posterior zone 2 only, but this is when the macula is only vascularized till when the vascularization reaches only macula, it is half, also zone half called. But what was important that we had an unfavorable outcome in 79% of the eyes with laser in posterior zone 1. So that is why it was so important to publish it and to bring it forth, that we can't simply go and get away and get such a poor outcome. So here you can see this is one such baby. You can see the vessels are stopping here, and here you have already some kind of a proliferation happening. This was very well lasered as much as possible. We left the posterior, but you see what starts happening. There is again contraction here, and finally stretch breaks happening. This happened once the baby came from follow-up and we saw stretch break. It's a problem. So we don't even know now what you can do once you have such a thing developing. So most would use anti-VEGF for APROP and zone 1, and anti-VEGF injection may be followed by less extensive laser. I think Prasann's case was very nice, and that is what we need, because otherwise we will have more problem, and frequent long-term follow-ups are required. Those are a problem, and late recurrences are also an issue. So I'll not go into detail the entire thing because the time is short. So as far as excessive retinopathy of prematurity is also frequently encountered in higher birth weight babies in developing countries. This is very important. And the management is a challenge. I already shown some of these cases. So combined treatment, anti-VEGF laser is required in many of them. These will not be just with one modality you will get over this. And you may even require early lens sparing vitrectomy in some of these cases. If the case is the way the Susanna also showed one where it starts sort of progressing, then we have to go very early in and do a lens sparing vitrectomy. They'll do very well. So thank you very much for this.
Thank you, Dr. Mangat. Excellent talk and your views on APROP. And I think you also, if I'm not mistaken, you also described the term hybrid ROP in your,
yes.
Yeah, you also,
hybrid ROP, the term was in fact coined by me. I gave that point. I didn't know. I used to write mixed ROP for a long time. Then once we sent it to publication, I put it. So I was told by the groups that they did debate about hybrid ROP in their group when I see ROP, but they never wanted to name it. That's why they changed it to aggressive ROP. So they wanted to make it like a compact thing. Yeah.
So any comments from Dr. Susanna and Dr. Subhata and Tapas?
Well, very nice presentation. And APROP is really a problem for everyone. So it's the disease we don't like to treat, because APROP, it's a spectrum. You can have sometimes the oxygen-induced retinopathy in the middle, those ANSA that you show. It's very difficult to treat those babies because it's an aggressive posterior ROP. It's simultaneously an oxygen-induced ROP. So you must treat the oxygen and the systemic and the eye, because if you just treat the eye with anti-VEGF, you still have, and the oxygen is not controlled, you still have the disease and have fibrosis and undo laser and have a fold, and it's very difficult to use it. But yes, it's a landmark when you could use anti-VEGF in these babies and everything is okay. And sometimes you have to do a second injection because the injection is performed, the first one is performed in the very early life of the baby, so it can have all the factors to have again a relapsed disease. But it was a miracle, really. It's an advancement. But as it's a spectrum, this disease, we don't know all this disease. So sometimes laser is a perfect effect also in combination. And sometimes I think the wonderful surgery, we must do a very early surgery, because the fibrosis that can go on and on. I think there is a place for every of these treatments, but still we do not know what's the perfect moment. So it depends on the experience of the ophthalmologist to know which one is better. If I inject and do immediately the vitrectomy, or in some cases I inject, I can do laser, and perhaps I don't have to do vitrectomy, but in some cases I must do vitrectomy to have good results. So it's still what is fascinating and ongoing science, you know, and it really still depends on the experience of the doctor, not just in artificial intelligence, you know. So still depends, I think, on the experience of the doctor, and it's not an absolute answer, and it's different from country to country. So there is a lot of factors. It's really multifactorial, and that's why we must make all together meetings from different parts of the world to understand what's the best way to face an aggressive ROP.
Just a
So
small
it's
point.
wonderful to speak about it and
Yeah.
to publish it.
Yeah.
It's very, I congratulate you.
Yeah, Dr.
I don't have
Subhadra.
the time.
Yeah, just a
Yeah,
small
yeah.
point that we have published, because when we operated these patients, we found that there was a lot of upregulation of inflammatory markers in the vitreous. We published that in Frontiers of Immunology. So clinically also, when we are looking at these babies, we must look for haze. Once the disease is completely gone, you will see that the media is absolutely clear. When it is smoldering, you will find that, you know, you can see all the vessels are thin and all the shunt, but you will find that the media is not very clear. So there is an inflammation. If we had a cell, you know, flare meter, we could have checked that. But clinically, you can make out that. I keep on showing this to the fellows that, look, this eye is not as clear as that other eye. So pick up this haze, grade 1 haze. If you see grade 1 haze, it means it's still smoldering. And we have shown that in
Excellent
Yes,
point,
and
Doctor. Excellent.
you have the
Excellent
white
point.
spots in the vitreous on the
Vitreous.
OCT.
Yes.
Also.
Yeah,
Yes.
excellent.
Yeah.
So that's the
Quick,
fair.
quick questions to Mangat sir. I was analyzing the very zone 1 posterior ROPs, and I could see quite a lot have these pre-retinal candle wax-like deposits. And I presented one case thinking that it is one rare occurrence, but I saw quite often they are present, and they are in many ways. Not only at vascular avascular junction, sometimes you see entire vascular area studded with these candle wax deposits, and those cases that do not have blood vessel within it, they just melt down with avastin. So what is your experience on their source, and why do they appear? And yeah.
Actually, I have no idea, but this is reported as part of hybrid ROP only. We had that thing that something is sticking over, and we even have a picture there. So I think I did discuss with you also a long time back, but we do not know what it is. So we have to really know more about it. Maybe there is something that Subhadra mentioned, inflammation, other things we do not know. We have to really look at. That is not neovascularization. We know angiography has been done in those cases. Though they are not leaky, they are different. And that's how probably they melt also once we
yes. And that need to be differentiated from a fibrovascular proliferation, because there if you give injection, you will be in trouble. I will be sharing this a similar case tomorrow in the series of cases, and again we'll take your feedback.
So with that, I would like to ask Dr. Subhadra, we're changing gears. We are now going to the surgical modality of treatment. So Dr. Subhadra is consultant ophthalmologist, and she specializes in ROP, and she's a network director at LV Prasad Eye Institute in India, and she'll be talking on indications and outcome of silicone oil in ROP surgery. So Dr. Subhadra, please, the floor is yours.
Thank you, and let's get on with the presentation. So we know that, you know, in the ROP retinal detachments are very different. A large majority of them are tractional, and we have to do a vitrectomy to remove those tractional components. But some of them can have additional exudative component, and we published that. But more recently in my surgeries, I have been recognizing that some of these detachments, which I thought were purely tractional, actually have a rheumatogenic component, and we can pick this up in the acute phase. I'm only talking of acute phase detachments. That it is more bullous, or it is more convex, or one part of it is convex. Then we realize that actually there is some break somewhere, and these are the eyes. When we do vitrectomy, the whole retina starts floating up, and then we are in trouble. So we are trying to recognize the acute phase regardees, which have not been reported much. Of course, a large majority of these babies come with bilateral detachment, so it's really challenging. We do bilateral simultaneous surgery in all cases. It is a very early phase of the disease where the detachment will occur. Obviously, if it is a zone 1 disease, the detachment will occur much more earlier and much more aggressive and faster. But we have to differentiate these cases from retinoblastoma. Only yesterday I saw a 21-day-old baby with bilateral massive retinoblastoma referred to me as ROP. And then viral retinitis we do see commonly, candida infections and other things. So all said and done, all these ROP detachments are progressive, and both the vision and the potential vision will progressively decline. So we have to really intervene immediately. I just wanted to show that, normally this is what we do. We do we find the traction. We may wait, it will always worsen. Nowadays, I don't wait. So here I didn't know, I waited, and you see in a week's time, how much of traction increased. I thought this is quite stable. It's very well lasered. And 5 days later, you can see how fast the traction and the fibrous proliferation happened. So I operated after this, got a good outcome. The retina could attach. We just do a lens sparing vitrectomy, shave off the vitreous, don't do any, silicone oil or anything. And they do well. Of course, today I would have operated at the first visit itself rather than wait for all these days. But these are happy stories which don't always happen. And here's how we, shave off the vitreous. So at the edge of the traction of the vitreous, these are, 1 year post-op eyes, we have shaved off the vitreous. We have not gone all over because we are at risk of creating breaks. So it's a matter of judgment. Again, where do we stop? Where do we stop the surgery so that we have done enough vitrectomy to prevent further detachment as the eye grows, but we've not created any break? So, so again, that comes with experience. You keep on, doing things. This paradigm shifts when we have anti-VEGF given before the surgery, because the more vitreous you leave behind, the more chances that there will be a reproliferation. So maybe in post-injected eyes, I would add more laser, or I would do a little more vitrectomy. But then I would also get into trouble. So now general thinking or general teaching is that, if a retinal break occurs during surgery, then most often these reg-RD eyes in a setting of acute ROP and traction, they fail. And that will be the end of that eye. And, you will have to just abandon that surgery. So sometimes we do attempt surgery with oil, and we are thinking that most of these fail. We are not able to reattach that retina. Here is one publication from Dr. Tracy's group where they said only 33% attachment in 18 post-op ROP eyes in this data. We know that in adults, silicone oil would give 50, 60, 80% success, but here the success rate is really low. So I would like to share my experience in about 50 eyes of silicone oil. And what we found was that the commonest site of break in our patients were either at the entry port. If the break is at the entry port, which I'm showing here, let's say we had lasered and at the entry port, in any of the 3 ports, there was a break. These are relatively easier to manage because the whole retina does not detach on table. You can do a peripheral cryo and you can put the oil, do the cryo. You don't have to drain much. And these eyes settle really well. There's no proliferation there. That retina is flat and it will attach. But if it is in the non-drag retina, let's say we were creating a PVD and there was a break created in this part of retina, again, there's a moderate difficulty. We need to create some PVD. We need to remove the ILM or the PVD. I will show one video. And these eyes also do pretty well with silicone oil. It's the ones when you get a break here where the retina was folded, lifted, fibrous proliferation. If a break occurs in this area, I think it's extremely difficult to treat because the vitreous is wrapped around this whole fold, both inside side and the outside side. And even with bimanual, you're not able to remove that whole thing and you're not able to flatten that retina. And so these are the eyes where really the surgery could fail. So I think when we document the silicone oil surgery or the breaks, it's very important for us to tell which area the break was and what did we do. And this we should document. So the problems occur in these eyes is, of course, creating the PVD and creating complete removal of vitreous, because the whole vitreous is very rubbery. And as I said, usually it's very inflamed. It's a very thick vitreous, and also it's very difficult to remove it. And it keeps on, sticking, going back. You keep on sucking it, it keeps on going back. And the retina is also very blubbery and very rubbery, and it's a very immature retina. So if there's a break, you will keep on extending more and more, and then you are in more and more trouble. So the retina doesn't behave, the detached retina and also the attached retina don't behave like the adult retina. You will find that it's more elastic. And of course, we have limited flexibility of instruments and space in a baby's eyes. Now, the peripheral retina could be avascular, it will be poorly vascularized, and then you will just create a giant retinal tear in that eye before you know it. And as I said, if the retinal folds are there, those would have abnormal adhesions of the vitreous, and that again becomes a challenge, how much to leave behind. So if the break is not in that area, we just shave off and don't try to remove that vitreous. So all these maneuvers which you do in adults like PFCL,
Apologies, Dr. Shubhadra, can we have 1 minute? 1 minute more, please,
Yeah,
if you
I'm
don't
just
mind.
going to give the solution. So the solution that we have is that don't do a complete PVD. Just do a focal PVD around the break and the retina will attach. Remove the oil very early. I remove it within 10 days because the retina attaches very quickly if it has to. If it doesn't have to attach, it will not attach by keeping the oil longer. And of course, then, if we think that we are not going to remove the oil, then we should use an oil which doesn't emulsify early because we are going to leave it for life. If there's a break in the periphery, we always support with additional buckle because, and also nowadays I do scleral imbrication for these eyes, and that is a good thing. Few eyes we have done fibrin glue assisted surgery along with the silicone oil, so they also do well. So I will just show a half-minute video about this very focal surgery that we do and not do a complete vitrectomy. This is less than a half minute.
Thank you, Dr. Shubhadra. I was actually looking forward to your talk. Unfortunately, because of shortage of time, we'll go on to the next speaker. So can I now invite Dr. Tapas Padi? Ranjan, Dr. Tapas Padi is a consultant vitreoretinal surgeon. Again, he practices at L.V. Prasad Eye Institute, and he's going to talk on something very important in the current scenario, impact of COVID-19 pandemic on ROP care, experience from Eastern India.
So very good evening, and thanks for the opportunity to listen to you all and share a few of my observations with you and get your feedback. So like we, those who are involved in the ROP care are used to obstacles, and obstacles make us better. So this is the COVID challenge, continuing ROP care, which is an essential care during this COVID period, was one such challenge which gave us many learnings in addition to the pain. So this is, I will briefly take you through this study, which was a retrospective study where we analyzed the impact of a revised care plan for ROP during COVID-19 pandemic from first April to August end in 2020. So it was for 5 months. So we took the same 5 months in the previous few years, 2019, 2018, and to analyze and find out the baseline characteristics of the ROP profile and outcome, the treatment plan. And this was as a issue, and it was approved by the institute. So what we did is basically I followed this five points, important points. One is protective measures. Of course, life takes an upper hand when there is the life and eye both are at compromise. So protective measures like basics of that of sanitation, the use of gloves, protective, social distancing, hand washing, everything from right from the first contact to the exit of the patient. Increased networking. So I would share with you how it helps us. So these networking and networking in a spoke and wheel model, like the networks which remains connected to you, helps us tremendously during this procedure. Teleconsultation, selected referral based on the baby's perinatal profile, like what is the gestational age, birth weight, which district it came from, what is the profile of an ICU where it was cared for, how is the weight gain. Almost one can mostly predict, what is the chance of this baby being developing a treatment requiring ROP. Selective, then a selective referral. Long and low follow-up of babies with less alerting ROP pathologies, and of course baby post-treatment follow-up. So this is how this is a brief overview of the social distancing, triaging at the check-in, history taking, which can be done even over the phone, and simultaneous with the dilatation. Some cases of home dilatation, like the time the parent reach you, your history and dilatation, everything is ready. Let's say for a few examples of the babies being seen, and this baby you can see, this is a very small baby, risky baby, right in the van itself, like the time the baby came, the history, dilatation, everything is ready, and we just saw the baby and send it off. So this is how the timing and the duration of contact can be reduced a lot, and the duration for which the patient remains and the parents remain in the hospital decreases. Intravitreal anti-VEGFs were preferred during this period over the laser, contrast to the other studies that I will discuss during the discussion. What are the reasons why we preferred anti-VEGF over laser? Now, briefly, these are the observations that we saw. The number of babies that we screened for over these 5 months were 222 compared to 624 in the previous year. But interestingly, the number of babies that we treated were higher and then the previous year. And so the proportion of babies that we treated were higher during this period. So as a result, the babies requiring treatment did not get missed during this period. So this is the total number of babies during the study versus the previous year. Then we saw that the number of proportion of babies that were seen in-house at the institute were more compared to the previous year, compared to our travel to the peripheral NICUs, where our partnering ophthalmologists, they kept on screening. Now, other perinatal profile, there was not much difference. The profile of ROP, we saw threshold ROP to be a bit more in the study period than in the previous year, and there was a delay in the initial presentation, significantly more in the study than the previous years. This is the treatment profile. What is most striking is this anti-VEGF. We can see that the number of babies that were injected with anti-VEGF was much more than in the study than the previous years. Outcome-wise, we saw that the babies, those who regressed, those who were regressing at the last follow-up were more or less similar. And so to summarize our finding vis-a-vis the findings that is already published, say for example from Chandigarh group, where the report said that both during this period screening and treatment both decreased. There was a preference for the laser. The surgical rate was higher. The incidence of iatrogenic conjunctivitis was less. Another study by
can you can you conclude
yes.
if you don't mind?
Yeah, just next 2 slides. So the IJO published in IJO, the screening and treatment burden decreased. And this one I want to highlight. They have more or less the similar babies screened during the COVID time, in fact, a little bit more. The reason being here, though they have a peripheral network where the babies were evaluated by the neonatal nurse itself. So the neonatal nurse sees the babies and sends the images to the main center. So that is why there was no change in the treatment plan. Vis-a-vis, these are our observations. Babies screened were less, but with the delay in the initial screening, but the number of babies treated and the proportion were more. Profile of ROP more or less similar, except a slight rise in the threshold ROP during the study period. There was a preference for Avastin, and outcome-wise there was no difference. So for the key messages or recommendations, so the strategy of protection and increased networking, tele-screening, and selected referral, long follow-up for babies with non-alarming findings, local follow-up post-treatment, post-injection can have what we saw, smaller pool of babies screened, but larger proportion of babies treated, and the babies target reaching the babies that require treatment, and none could get affected with the ROP itself. So thank you all for the opportunity. I finish here. I can take it.
Thank you, Dr. Tapas. With that, we have to conclude the session because the next session is going to start. I would like to thank Dr. Mangar, Dr. Susanna, Dr. Subhadra, and Dr. Tapas. Very exciting discussion, and hopefully we can continue tomorrow in a continuing session of ROP. Thank you, everyone. Thanks a lot.
Thank you.
Thank you. Thank you. Thank you.
Thank you. Thank you. Bye.
Thank you. Wonderful. Thanks.
Thanks. Thanks.